Join us every Wednesday for InFocus, a weekly talk show produced by the St. Kitts Nevis Information Service, where we provide exclusives with key persons within the government and discuss pertinent, relevant, and interesting matters that affect us all. Tune in every Wednesday, live on ZIZ Radio and streamed live on Facebook at SKNIS Media and ZIZ Online. InFocus, your government, your business.
I'm Ian Richards, welcoming you to InFocus, a weekly program that takes a closer look at what's happening within and across the government of St. Kitts and Nevis. Well, recently the Ministry of Health announced several major developments, from new leadership appointments within the health system and the arrival of nurses from Ghana, to the expansion of cardiac services at the Joseph N. France General Hospital and continued upgrades to healthcare facilities. Today we'll explore what these developments mean for you, patients and healthcare workers alike, as the ministry continues efforts to build a stronger, more resilient healthcare system for the people of St. Kitts and Nevis. Well, joining us today for this discussion are Dr. Rondalyn Dennis Bradshaw, Principal Nursing Officer, and Dr. Jenson Morton, Director of Health Projects and Strategic Initiatives. Stay with us for InFocus for a discussion on building a strong health system.
When we took office, the hospital was leaking. We had very few specialists at the hospital. Hardly, at one point, there was one ambulance. I could not even say that to the nation. One ambulance. And we decided we are going to reprioritize. It was not our objective to just buy a whole fleet of ambulances and invest so much. But when you recognize these critical areas were in such bad shape, we had to reprioritize and channel our monies and resources to these areas that we did not recognize we would have had to spend so many millions on. We brought in the fleet of ambulances, never to go back to the point where ambulances are cutting out in the middle of the road and running out of oxygen. We have passed that. We have invested heavily in the roofing system at the hospital, even though it continues to be a challenge, but it is better.
Welcome back to InFocus, and you would have just heard from Prime Minister and Minister of Health, the Honorable Dr. Terence Drew, as he shared a bit about some of the upgrades taking place within the health system. And we can explore a lot more about that now during our conversation with, as I mentioned at the top, the PNO, who is the Principal Nursing Officer, Dr. Rondalyn Dennis Bradshaw. Welcome, it's your first time here, it's good to have you.
Good afternoon, Mr. Richards, thank you for having me.
And of course, we have Dr. Jenson Morton. Dr. Morton is no stranger to InFocus, no stranger to the media. It's always good to have you, sir.
Yes, good day.
All right. So we have a lot to cover. We'll jump right into it. And I should mention for our viewers that, of course, we originally scheduled this interview, Dr. Morton, for July 1st, and we had to postpone, and that was on our end, and we apologize certainly to our viewers for that. But since then, we've seen several key announcements made by the Ministry of Health, particularly on the human development front. There's a new director of institutional nursing services in the person of Nikisha Hazel, and there's also your former position, the director of health institutions, and that's Mrs. Gardenia Destang Richardson, and
yes.
Of course she's a former National AIDS Program Coordinator.
Yes.
Now, can you talk to us about these appointments and how they help to shape, more so improve quality healthcare in St. Kitts and Nevis?
Okay, I'll speak to Mrs. Destang Richardson, and I'll have Dr. Bircher speak to the new matron of the hospital. So Mrs. Destang Richardson, she's no stranger to the Ministry of Health, as was stated before. The position of the Director of Health Institutions, it would have been a pre-existing position that was inherited. And at the time, the administrative framework for institution-based health services, as well as the Ministry of Health, it had its own setup that was convenient, or that was best suited for that point in time. Since then, we've had some changes, one of the main ones being the, what we call the Director of Health Institutions, and that was the Ministry of Health. And the Director of Health Institutions, it would have been a pre-existing position that was inherited. And at the time, the administrative framework for institution-based health services, as well as the Ministry of Health, it had its own setup that was convenient, or that was best suited for that point in time. Since then, we've had some changes. One of the main ones sheer scale of the amount of new health projects that we were bringing on stream, as well as the appetite, thanks to the new Minister of Health, this new appetite that came on stream for modernizing and professionalizing our health service, which highlighted a long list of areas that genuinely needed changes and upgrades, and there was now the political will to do so. So not just myself coming on stream, but Dr. Bercher coming on stream and lots of other persons that were willing to initiate all of these changes. Now, one of the areas that got stressed would have been the DHI position or the health director position, because not only would it have involved the management of the current hospital as the final person in charge, but you also would have had overlapping with that aspects of public relations and communications, ultimate aspects of human resources, and then on top of that, the tasks of accreditation, the tasks of corporatization of the institution-based health system, as well as now the big kahuna of the new hospital, and to upgrade the services of the current hospital. So you can't leave the current hospital to just wither, because it's going to be incorporated into the overall framework. So to summarize, that's a lot of work for one person. So it was identified that the actual health administration component, it's best if there's a separate focus on the projects component separate to that. So the difficult part now would have come for, well, who is a good person to now put in the position of health administration? And Mrs. Destang Richardson, practically a godsend, because she's someone that has the level of experience in working in the Ministry of Health. No stranger to the system, no stranger to the operations of it. Did an excellent job when she was AIDS coordinator, National HIV and AIDS coordinator. Made us a regional leader with regards to our organization of our response to it. And it was just someone that had proper training, right temperament, right everything to basically take on that task. So instead of it being us having to onboard someone that would need a lot of training, it was more so just bringing up to speed someone that kind of knew everything already. So it's been very good, and it's allowed that dual-pronged focus to exist going forward.
And Dr. Dennis Bradshaw, we could speak to Nikisha Hazel, who is new in that post.
Right, so Ms. Nikisha Hazel comes at a very good time when we are making changes to our leadership at the level of nursing services. She comes with 27 years of experience in nursing services. Persons would recognize her working in community at the Newtown Health Center, and also she worked in hospital a few years, but through her educational qualification in community health, public health, also she was also an adjunct lecturer at the college, the Division of Health Sciences, and she has qualifications in health policy, health administration, and she's also the chair of our nursing council. So with that, she comes with an in-depth leadership, knowledge, and expertise. Also, to support her as well, we are going to be introducing soon 2 deputy nurse directors. One will be responsible for clinical operations and also for patient safety. The other deputy will be responsible for human resource and also continuing professional development, which is important in ensuring that our nursing staff, the capacity is there to support the leadership at the top. Of course, we're going to maintain the assistant director posts. So the 4 persons at the top will help to manage adequately the hospital's leadership, because we have 4 hospitals that the matron or the director solely was over all these institutions. But now we have introduced new leadership to assist the matron or the director to ensure that persons are provided the care at the level that they're expecting.
How would you respond to someone who would question why these new positions in terms of deputy are being installed? Were they on the books before, or is it new positions?
No, it was not on the books before.
There's someone who was questioning why these new positions are needed.
It was not on the books before, but as I said,
why not? Why they weren't there before?
Yes, as I said, when I came into my post, I recognized that we only had one director. And if you have 4 hospitals under the leadership of one nursing director or one matron and an assistant director, of course the capacity of care, you will have a lot of gaps, right? And so the oversight of the whole institution in nursing is very wide. Nurses, we are the ones who are the majority in these institutions, and the proper guidance and leadership is what we need.
And it should also be noted that when I said why not, St. Kitts and JNF Hospital, just as a focus, even though it's broader than JNF, the total bed count and patient load that we have annually, it far exceeds what is currently, for example, experienced in Nevis. But Nevis has 1 matron with 2 deputies, and we only had the one with the 1 assistant. And it's also more than in Tortola, who has, what does Tortola have, 1 and 3?
1 and 3.
1 matron with 3 deputies. So we were actually behind with our management. We have more staff than them, more patient volumes, and it was something where we were just lagging behind.
So it's a best practice.
It's a best practices, yes.
Right.
Yes.
Okay.
And since we are running towards accreditation,
Yes.
these will be some of the standards that are expected.
Accreditation of
The hospital.
Of the hospital.
right. Okay, and that will be done by which board?
Accreditation Canada is the first one we're looking at. It's actually something that we had been the government of St. Kitts and Nevis had been exploring since 2003, on again, off again. But this is now a new thrust that we are taking with regards to getting this accreditation.
Just quickly, what's the benefits of being accredited?
Well, in this modern term, especially post-COVID, you need your accreditation as your international stamp of approval that your hospital standards are at a particular level that's deemed acceptable. Before COVID, I mean, it always existed, but before COVID, it was deemed acceptable sometimes to just state, you know, my hospital, for example, you could say my hospital has a CT scan, my hospital has a lab, my hospital lab can do this, I have this amount of staff. And some places were doing that. When COVID came and you were absolutely locked off, all countries and institutions got the ultimate test to see if, well, you said you have it, is it working, is it functioning properly? And it was reflective in some of the outcomes that were seen in some places. Since then, investments, especially places for investment and other agencies, they are now sometimes avoiding investing in places if they cannot see a stamp of approval from an international body that says that you're accredited. It impacts everything. Even when we're trying to sell something like villas or condos, some persons would say, I want to retire here, but I'm not going to retire here if I don't see that your health institution is accredited by this body. It doesn't matter how nice or fancy it looks. It could look bad, but if you're telling me it's accredited, I know it looks bad, but it saves lives. If it's not accredited, I have to take your word for it, and sometimes they say, I'll just look for a place that has it. And it's been happening more and more as time has gone on, so we can't kick the can down the road anymore.
And that's critically important, I think it's in Nevis, the tourism aspect of it,
yes.
Especially with Morton.
Yes.
To start coming to St. Kitts and Nevis to catch a boat or cruise ship, you must have those medical facilities in place that are accredited. I want to come back to the position now that Ms. Hazel occupied. And on Tuesday, we saw, of course, the official sashing ceremony, I believe that's what you call it in the nursing field, to mark the appointment of Ms. Hazel. And the Prime Minister, Dr. Terence Drew, the Honorable Dr. Terence Drew, he shared remarks. And there's something he said that really stood out to me. And I'd like you to take a listen to it, and I'd like you to come back and on the back end and share your thoughts on it. We listen to the Prime Minister now.
Your achievement today should also serve as an inspiration to every young nurse who may be contemplating the possibilities of his or her professional journey. Your story offers a powerful message. With commitment, continuous development, discipline and opportunity, there is room to rise, to lead, and to make a lasting contribution.
So the Prime Minister basically spoke about Ms. Hazel rising through the ranks. How important is this for persons who she needs now, for persons who are entering the profession?
Well, it is important.
Go ahead.
It is important because, of course, as I said before, she is well read and she's an expert in her field of leadership. And of course, we want to ensure that we support our nursing leaders through training and prepare them for the leadership roles. And she has been through the ranks. And so we want to also use her position to encourage the other nurses within the hospital for continuing professional development and to reach these, aspire to the leadership roles that we have available for our nurses. So in bringing her on board, we are quite happy about that. And of course, our nurses have already started to accept the new leadership.
And conversely, Dr. Morton, as we look at Mrs. Desang Richardson returning to public service, as I mentioned, she's quite distinguished service when she was National AIDS Coordinator, leading St. Kitts and Nevis' program to one of the best in the region.
Yes.
What made her the perfect candidate for the post? Because there's some persons who may question why she's being brought back into the service.
Well, for those persons, I have to understand that even when she left the service, it was a graceful departure. It was a personal decision, graceful departure. It wasn't a departure under duress or anything like that. So just as it was a graceful departure, with her returning full-time to the Federation and with the vacancy aligning, it was just to have her being brought on board because, like I said, she is someone that had all of the necessary qualifications, apart from the experience, master's degree in psychology, master's degree in public health administration. It aligns very well with what we are trying to achieve, especially in the areas of the same accreditation, the same corporatization, improvement of standards across the board, and also with that background, you know, someone that if something sensitive happens, that can approach things with empathy, impartiality. Those are very good qualities that when you are in charge, well, when you're the ultimate person in charge of an institution of 500 plus people, those are very good qualities to have. So, very much so.
And I imagine that's why you described it as a godsend.
Yes.
Okay. So, and also moving back to so many updates that were given, as I mentioned, since we had originally scheduled our interview. On July 1st, we saw an announcement that 47 nurses from Ghana were welcomed to the Federation. And it was done under a bilateral labor agreement. Can you share more about this agreement?
First of all, 47 nurses did come into St. Kitts on June 28th. We are very happy that they are here. I would like to just give some background as to how we got to this point. Now, Ghana has at least 78 public nursing training institutions, and they graduate at least 4,500 nurses annually. Currently, Ghana has a population of 35 million. They also have between 70,000 and 100,000 nurses who are unemployed. Now, the government of the Republic of Ghana indicated that they had to come up with out-of-the-box solutions because you can't have all these nurses who are unemployed. It means that they're not earning a livelihood. So the process of having bilateral agreements with countries came into being. St. Kitts is one of 14 countries who have signed on to those, the BLA. And we have countries near to us: Barbados, Jamaica, Dominica, Bahamas, Grenada, who have also signed bilateral agreements with the Republic of Ghana for nurses. Of course, the nurses who are here, they are on a 2-year contract. And in the first instance, of course, they would have the opportunity to renew for another 2 years. Once that cycle of 4 years have been completed, they have to return, and then others will follow to fill those gaps. The qualification of those nurses coming in is 47. So 16 public health nurses, trained public health nurses, will go to the community health setting. 31 registered nurses will be deployed to the institution-based health services between medical ward and the private ward. But before we had the BLA agreement, we already had recruited 21 nurses between December last year and June of this year. Among those nurses, we would have had 2 mental health nurses, and those were deployed at the community health services. Then we had 3 emergency nurses at the accident and emergency department, 3 peri-operative nurses, and those are nurses who actually prepare the theater for the surgeons to commence their surgeries. Then we also have 1 nurse who is ear, nose, and throat, and that will be an excellent addition to the outpatients department. We also have within this BLA agreement now, we have specialized nurses as well. So we have another additional 3 emergency nurses, and of note, the emergency nurses are also trained as trauma nurses and flight nurses. We also have in that group 3 perioperative nurses, 4 psychiatric nurses, and this is a welcoming addition for our psychiatric ward at the hospital. So we have those persons going to that unit. We also have another neonatal nurse in that batch that will be assigned to the maternity and neonatal unit.
So these services seem to be very specialized in terms of filling a gap.
Filling the
Yes.
gap. Yes.
Yes.
Okay, and as part of this bilateral agreement, the nurses are here. Will we see any transfer of knowledge, any transfer of skills taking place?
Well, that is something that is being developed in the bilateral agreement. However, we have started with the 21 nurses that we have in hospital and community. Especially in hospital, we have already started to use one of the emergency nurses to provide continuing professional development in, for instance, recognizing deteriorating patients, and that started last week. Of course, we have the opportunity now to broaden their use within our systems in helping us to certify our nurses in community health, perhaps, even give them some continuing professional development in the area of critical care and other areas, and especially perioperative, because that can be practical, done in the theater as well.
Has the recruitment of nurses from Ghana impacted the recruitment of local nurses? Does it encourage or discourage, based on what we've seen, persons who to join the field? And also, what about those who are considering it? Do we have an idea how this is going?
Well, we continue to work aggressively to recruit local nurses within the hospitals. Very good news I got today is 6 of them completed the BSN program at the college, and they have already registered for the regional examination for nurse registration. That was done this morning. So we know that we are going to have 6 local nurses coming in. Of course, we have to continue the work that we are doing to reinstate the associate degree, to complement the Bachelor of Science in Nursing program.
That's at CFBC?
That's at CFBC,
college, right?
yes. So what we want to do, we want to have another pathway where we can increase the amount of nurses coming into the profession, and also increase the capacity of local nurses within our hospitals and within the community as well.
Dr. Morton, similarly, I ask, how have they fit in, the nurses from Ghana? How have they fit in? And do you get a sense that they are gelling with our local nurses?
Yes, they've actually fit in very well. Thanks to the 21 that we had recruited before, it gave us like a little preemptive view with regards to what might be any kind of, let's say, clash of any sort. There hasn't been any cultural clash. Thing number 1, that's a good thing. They look just like us. That's it. That shouldn't be understated. So it's not to say that you look at them and you can point out some obvious difference between them and local persons. That's just building on persons that might want to push a stereotype of some sort. It's not there. The other thing is that culturally we are actually very similar. The differences are not that vast, and the work ethic that they have is very good. The professionalism, the competence, because we have the advantage of course, we interview everyone before they come, we check through all of the credentials. We ensure that good staff are the ones that are coming, and it has been proven with them beginning to work. There have been It's the exact opposite. Instead of complaints, there have been compliments coming repeatedly from both the physician staff that has to work with them as well as from the general public that has interacted. So it's been pretty good. One thing I would add to the recruitment part is that a hurdle that we try to get over in nursing here is to try to get more males to be looking positively at nursing. The good news is that other countries, they've already crossed that hurdle, and you have both genders involved in nursing. And even in the Ghana set, I think the 3 for the emergency room, I think all 3 are male nurses, and all of them have military training and all kinds of stuff. So it lets people know that yes, you can do nursing as a male, there's nothing wrong with it. And like I said, you know that, or even on the military aspect of things, there can be the cross-training of that with the medical care and the emergency medicine part in particular. So it's helped.
And patients, how do they respond to the male nurses? Because as you mentioned, it's unusual for you.
I haven't noticed any problem. As a matter of fact, when with the, I don't even want to say this, it's a bit sexist, but with the emergency room staff, when you have male nurses, it's nearly like having a nurse and an orderly putting. I shouldn't say that way, but of course, if you have to move, push something heavy, you would need some assistance. Sometimes with the male nurses, they basically it's the nurse and the orderly in one.
So they take charge.
So not so much taking charge. They can function and move and shift things even if we're having an orderly shortage. So there's a little plus to it. So the female plus might be the soft skills empathy side, but the male plus is that thing which I would have mentioned. So there's a strength in everything.
And good news for us, out of the 6 that have completed the program at the college, 2 are males. 2 are males. And I find that patients gravitate more to the male nurses, especially female patients gravitate more because they say they're more gentler than the female nurses. Yes. But apart from what you said, in addition with the increase of nurses that we now have room to expand, to encourage our local nurses to go off and do specialty training, right? For instance, we are going into the health information systems. And so we need nurses trained in health informatics. We have one nurse who is trained in health informatics. She's dual trained because she's also a critical care nurse. And so we need persons trained in that area. We also need persons trained in emergency nursing, local nurses. One nurse has actually put forward her name. And so we are now in the process of getting her to go to Jamaica and get the emergency nurse training done. Also, we need more nurses for palliative care, elderly care, also public health nurses. We need more nurses because when I look around at the population, we are getting older. And so we need to encourage the younger nurses now to come up to the plate and go off and do their specialization. So now with this influx of nursing now, we have enough wiggle room now to encourage our nurses to go out and study and specialize. Education is another issue. Nurse educators, we do not have enough. And if we want to train local nurses, it means then that we have to build the capacity to increase our nurse educators' existence within the college. And so that is a very grave concern because we cannot have trained nurses if we don't have enough nurse educators in place.
Right, and finally on the nursing question, because we're almost at the bottom of the hour, so we have to move on to something else. But does having the nurses recruited from Ghana affect nurses being recruited from other countries?
Well, when I did the workforce plan for 2026 and 2030, we had capacity right now. Perhaps in the future, we can look at other areas. But for us now, we are satisfied with the level of nursing care that our population receives, and we are satisfied with the specializations that we have recruited. The only concern for us right now is getting our local nurses at that level of specialization.
And so being exposed to these nurses, that certainly will rub off. And
yes, we hope, yes, right. We are hoping.
And all of that will lead to better quality health care for patients.
Yes,
absolutely.
Of course.
Right, okay, so we're going to take our first break. Stay with us, viewers and listeners. We'll be right back with more In Focus.
If you haven't done it as yet, Please do it today. Subscribe to our YouTube page at SKNIS Media for regular updates, live coverage, and even more information on your government. While you're at it, like, share, and interact with our Facebook and Instagram pages at SKNIS Media and SKNIS Info.
Welcome back to InFocus. We continue our discussion with Principal Nursing Officer Dr. Rondalyn Dennis Bradshaw and the Director of Strategic Initiatives, and I'm sorry I forgot the other part,
Health Projects.
Health Projects, Dr. Jenson Morton. All right. And as I mentioned, Dr. Morton, we spoke about announcements by the Ministry of Health. There was also another announcement on July 4th, which spoke about an advanced echocardiogram, and that's heart ultrasound. I'm reading the medical term, so excuse me. The Prime Minister actually posted this. He mentioned that these services are now available at JNF, another major step in expanding quality health care and bringing modern cardiac care closer to our people.
Yes.
How prevalent are cardiovascular disease in the Federation, and can you speak about its impact on the population?
Yes, cardiovascular disease is a major problem in our federation right now. It's been our #1 cause of death for the past 5 years. And even outside of it being a cause of death, it is also a major cause of debilitation and persons being unable to either work or live to their full extent.
And I'd like you to break down some of the diseases
that includes heart attack and stroke.
Right, okay.
As well as heart failure and quite a few other things. So we never had a specialist to help attack that problem from the angle of the institution, as well as even to give some more teeth and strength to attacking it from the aspect of community health and preventative medicine. We did have some programs running, such as the Hearts Initiative and other programs which helped to target reducing rates of obesity, hypertension, diabetes, and other things that can lead to the development of some of these cardiovascular problems. But in the event of someone presenting to hospital in the acute setting, they're having the heart attack now, etc., etc., we did not have the full levels of expertise on hand in the hospital setting to be able to deal with that presentation. We always had our ways and means of dealing with those situations, but the absolute gold standard really is to have someone that's an expert in the area on hand as a member of staff. We've had a vacancy on the books technically for a cardiologist. I came in 2022 in terms of management, and I saw it existing on the books from 2022. It was just unfilled. It's something that was recognized from some time back. Dr. Oliveira is someone whom we would have identified since 2024 as someone that could be a great addition to our staff, but he was just in very high demand. So he was recruited to work in Jamaica, most recently in Kingston Public Hospital, as well as in the Heart Institute in Jamaica. And that stint would have ended in 2026. So just as that stint ended, we went and approached before any reinitiation of a contract could take place, and we were able to be successful to get him to join the system. So him being present, it assists us in multiple ways. So the first thing would be the provision of echocardiograms. So as you mentioned, an echocardiogram is an ultrasound of the heart. And we have had ultrasound machines given to us by a partnership with the government of Germany via Special Envoy Dr. Amar Martin. And those ultrasound machines, 3 of them, they would have been delivered to us since 2024. And we would have made the announcement of the arrival of the machines, but I don't think persons fully grasped the importance of it. Nearly any ultrasound machine, if it has the right software and if it has the right probes and if it's advanced enough, they can also do echocardiograms. So we had these machines with this ability. We just did not have the expert to be able to offer the service. So that person now coming into the system, it means that we can now use the equipment that we gathered to the full potential. So all of this was part of a larger scheme, set of plans to get things done. Now, even though we have the offering now of, okay, we can do emergency echocardiogram services for persons that have certain presentations. We can also do them for inpatients, and if you get a referral from one of the health centers, we can also do them on an outpatient setting. The outpatient numbers might be a bit drastic for us right now, so we're going to have to try our best to manage them. But it's more than that. Dr. Oliveira, he also is going to be eventually working with a full team that will consist of 2 nurses, which he's going to onboard and train as, in-house train as cardiovascular service nurses, as well as 2 physicians. He will also have train with him such that for any inpatient in the hospital, they can get access to 24-hour coverage if they've been admitted with a cardiovascular ailment, which is something that to have that kind of on-hand to have that level of on-hand service is something that we have not been able to 100% achieve to a gold standard before. This is something that we're working towards. He also would have refined the protocols that we had with regards to the management of certain presentations that patients can come to the emergency setting with, as well as patients that would have been on the ward that develop particular symptomatology. This is what you do in this particular manner. These are the persons that you call, these are the tests that you do, these are the medications that you employ, these are the results that you're looking for. And he has had those refined, and we're going to be doing the continuous medical education sessions for those. And apart from all of that, the one final piece is that if you look at Dr. Oliveira, he is actually an interventional cardiologist. So to explain, a cardiologist, of course, is in the school of medicine, which is in medicine and therapeutics, which means you try your hardest not to do, you don't do invasive procedures. But an interventional cardiologist is someone that's like on the brink. You can do certain procedures that are a little bit more on the, as the name gives away, interventional side. So it allows you to do things such as stenting if someone has a blocked or an occluded artery in their heart attack. That's something that we currently cannot do. None of the islands in the OECS currently can do that. If someone gets the presentation of a heart attack in which it can be stented, that patient will have to be flown to Trinidad or Jamaica, well, usually the Jamaica by the Heart Institute, or in Trinidad, that's another choice, or to the USA for them to get the stenting. And the time, every hour counts when that happens, so we don't have much time to play with. The sooner you can get them to these centers, the better it is. So, like I said, that's been a limitation not just for us, but for all of us in the OECS, and that's called cardiac catheterization. It takes special equipment, special non-reusable parts, as well as a specially trained set of additional staff. Dr. Oliveira, he does have the ability to do the interventions, but we do not have all of those things for the cardiac catheterization. His presence here is to assist us with the groundwork needed to ensure that we can get such a system in place, especially with regards to the new national hospital, in which one of the centers, one of the pre-planned centers of excellence, as highlighted by the Prime Minister, is cardiology/interventional cardiology/cardiac care. That's one. Another one is oncology. Another one is nephrology/urology. So him being here is to help to build out that framework such that when the time comes and we have all of the infrastructural settings in place, that we can enter with all our pistons firing to get that done. So that will, like I said, broaden our aspects of what we can offer. But in the absence of that, he can still help to optimize those patients as we prepare to send them off for the treatment. But like I said, it's not really a specific paucity in the St. Kitts and Nevis health system. When we get this done in the new hospital, we will be the smallest place that has the ability to offer such a service. Well, in the public system, sorry, you have, I think Tortola does it privately, so the smallest in the public health system, because one of the reasons why the other islands don't do it is cost.
Right.
So, but we have something set up to make it effective.
Let me come back to some things that you said. That was quite a mouthful. You mentioned in terms of the locals, you mentioned in terms of training 2 doctors and also some nurses as well too, taking them on board to work with them. Will that be among the local staff or they will be recruited outside?
No, we'll aim for it being local staff. We want this to be long-term, one of the options for long-term development.
Right. Okay. And you also mentioned that he was working in Jamaica prior to coming here to St. Kitts and Nevis. So how long is he here for in St. Kitts and Nevis? And what essentially, if you can very quickly share what tipped the scales, why did he agree to come to St. Kitts and Nevis?
Okay, well, this initial contract is a 2-year contract, but his decision to come to St. Kitts is when you speak with him, he'll tell you if you get the opportunity to interview him. He had looked at St. Kitts for quite a long time because of just to summarize it, just the quality of life aspect of things here. I think people that live here take it for granted how nice it is to live here. But other people, they know how nice it is to live here. So they investigate and they realize, hey, this is a place that the work-life balance is very good. Everything with regards to quality, the access to services is very good. So when people complain about things like water and electricity, it's like, y'all don't realize that for a tropical island or a tropical setting, we have it pretty good. So other people know this, and looking at the options that he would have had available, St. Kitts and Nevis was a very attractive option to work at, and many people share that same point of view. So usually when we're recruiting, it's really not that difficult to, well, depending on what we're recruiting for, it's usually not that difficult to get people that see the opportunity that's there to live and work here, and they jump at the opportunity.
Well, we mentioned quite a bit in terms of the specialists, and I think we can spend the rest of the program talking about the specialists who've been brought on board since 2022. But we're not going to do that, of course. There's so much to cover.
No, we have specialists. We have both specialist doctors and nurses. We can speak about it.
Right, well, we can, but I want to ask a specific question about it, because you mentioned oncology. Of course, you spoke about the cardiovascular aspect of it. You spoke about nephrology as well, too. Have we seen an uptick of persons coming into St. Kitts and Nevis for specialized treatment now that there are so many specialists who are being brought on board?
Yes, we have. We have already seen St. Kitts starting to turn into a referral center for some of the neighboring territories. We get patients referred to us depending on what they present with. We have had patients present to us from St. Eustatius, from Anguilla, and of course in St. Kitts we'll accept if for any reason Nevis cannot handle a patient, we can, and it's also vice versa on the Nevis side. And we have started looking at the option of persons traveling from further afield to come to St. Kitts to get certain procedures done, to then recover in privacy and then to return to your country of origin. So we have been seeing that increase, and our hope is to just continue building on what we have to improve and continuously improve our reputation, especially with the accreditation, which would be the final stamp that we need to easily or more easily get persons coming from further afield, like the USA. If they see that, they will opt to come to St. Kitts and get certain things done, and that can help us economically as well.
As we speak about specialists, of course, equipment is important as well too. And one of the things that the Prime Minister has been very passionate about is having MRI services introduced here in the public sector for persons to be treated. What's the latest on that?
Okay, well, the actual building for the MRI, it's, you could say 95% complete. The building itself is done, if I had to put it that way. What is outstanding is just some electrical work and then some final work with the air conditioning system. Once those are complete, the next thing will be the construction of the Faraday's cage. That's the protective system that's going to be around the giant magnet, that's the MRI. The company from Florida is going to come and install that, and after that is in place, the final part will be the actual delivery and receipt of the MRI machine itself. Now, the reason why we have to be a bit cautious with the MRI and we can't rush it is because an MRI is not like when we did the CT scan. A CT scan, like a CT scan or an X-ray machine, ultrasound machine, those are just machines. Meaning, when you import them, you can pack them away somewhere. You just have to make sure it has like AC and stuff, and you can pack it away somewhere and then install it when you're ready. An MRI is basically like, you can consider it to be a human organ. it has to be plugged up and it has to be kept in these optimal conditions. Otherwise, you can consider its reactor to break down and you lose your whole investment. So we cannot just ship it and then just have it and not have everything in place such that it can be installed practically immediately. So we cannot ask the company to even, when the company puts the final touches on the machine, it only takes them 2 months to put in the last installs. So they need to find out for sure everything's in place, they can start the last 2-month process, and they've gotten into the habit of finish absolutely everything and then we start, rather than seeing it 95% of the way complete and then saying, okay, we assume you'll finish the last. This actually say no, because in some other territories, they did that and that's what ended up happening, and your millions of dollars worth of investment got wasted.
But you can't predict disasters.
There you go.
Predict the shortage of construction equipment.
And we don't make anything here. So all of those things are some things that that can cause some delays. So we have to make sure that everything is in place so that when it comes, even down to the logistics of getting it from the port immediately, so it's not something to offload and wait in a shed. No. The boat comes, your logistics is there, something has to be sped up with regards to, of course, customs, customs has to do all of the legal relevant checks, but it has to be in a manner such that it comes, you have your logistics people, they deliver it straight to the hospital, the team from Florida as well as our local experts are there to do all of the installation immediately, because there's a 14-day window that you have to do that, which is on paper plenty of time, but it gives you room if anything goes wrong that you have 14 days to resolve it, such that you can get this thing installed and up and running. Then after it's actually installed, the only things to do would be to train the actual staff in its utilization, as well as to train our local engineering and maintenance staff with regards to the basics of maintenance and the basics of troubleshooting. And after those are done, that's when we can have it available. So we're looking at like late September, early October.
All right, I was just going to ask that because based on what you said, that's 2 months and 14 days, 2 months to complete the complete construction of the MRI, 14 days, of course, to have it cleared, and then the training would be another. So that would take up to September 2026. Okay.
So it might be an independence gift. Oh, it may be a little bit after independence. I'm hoping it could be an independence gift, but it might be a few days after.
We certainly look forward to that. And there's been so many announcements that have been made as well too. There's another announcement that the Prime Minister made, but we're going to take a break and hear that announcement before we come back and talk about it. We'll be right back, viewers and listeners, for more in Focus.
I want to announce today that we have now fully AC'd the hospital. We have AC on medical ward, surgical ward, oncology, pediatrics, obs and gynae, outpatient department, all of the departments, and the areas in the psychiatric ward where we can put them as well. So for the first time, the hospital is fully AC'd out. And why we do that? That was part of our plan, because again with climate change, the temperature was rising. So I went there yesterday to see the system. The nurses and patients are extremely happy that now they have a hospital that is fully AC.
Welcome back to InFocus, and we continue to have our discussion, and we're in our last segment with Dr. Jenson Morton, Director of Health Projects and Strategic Initiatives, and also Dr. Rondalyn Dennis Bradshaw, who is the Principal Nursing Officer. So we move on now to something the Prime Minister spoke about, and that would be the improvements that are made at the JNF. And as you mentioned, Dr. Morton, it's not going to be abandoned. No. The hospital still has to be upgraded because there are so many gaps that were there.
Yes.
And so tell us a bit about something what he spoke about. And we've seen physical upgrades to the JNF, from the lobby to the laundry area to the morgue, and of course to various wards as well. And the Prime Minister spoke about the private ward, and he spoke about the fact that all of the wards at JNF now have ACs. Talk to us a bit about some of the importance of having the AC system on the wards, and also the private ward, which is scheduled to be reopened pretty soon.
Okay. So, yes, we now have temperature control for nearly all the wards. The exception right now is the psychiatric ward. We're having some challenges with we're having some challenges with getting the infrastructure in place without it being damaged. So we're trying to look at some options that other countries use to try to be able to extend that service to them. But with the exception of that, for medical, for ICU, for surgical, for pediatrics, for maternity, and for private ward, all of those other areas, they are fully air conditioned now. Very good, because of course, good temperature control and having an ambient temperature for the patients to be comfortable, it assists in all aspects of healing, especially now that we are having all of these increased temperatures because of climate changes. We want to ensure that the patients are comfortable in the hospital and they're not, I mean, what's the worst thing if someone comes to hospital and they get so hot that they get like a mini heat stroke or something? So having the temperature control is important. When the hospital was first built, we weren't seeing temperatures like this. And it was just built to basically capture breeze to allow that to be the main way to keep it cool. And it was adequate when it was first built. It's no longer adequate. Nobody could have predicted those changes. So as those changes occur, we have to adapt accordingly.
Of course, we know the private ward was used as an isolation ward for COVID-19. Some persons may be concerned about going there, that there may be some risk in terms of any diseases or any viruses that may linger. What's your response?
No. The last patient that would have been there would have been early in the year in 2022. Since then, thing number one is that our institution, in keeping with international standards, we have our infection control team. That team does routine swabbing of all parts of the hospital on a monthly/3 monthly basis, depending on what they're checking for. And it's always been returned as being negative for any variant. First of all, it's not going to survive on the outside for that long anyway, but that's another story. Other things might be there, but but that's other things might be there. Nothing is there because of the test results that have come back. And apart from that, we've done multiple rounds of deep cleaning of the same area. The main issue that we had with the building was that after we stopped using them for COVID patients, it was closed up for quite some time. And two things ended up happening. Thing number one, the temperature plus the humidity made it capture some mold. And then thing number two, a leak had actually developed in the roofing in the area, and because it went unaddressed when it started off as a small trickle, it actually had become a very big problem by the time we would have reopened the ward. So the entire roofing system needed to be redone, mold remediation had to be redone, all of the AC units had to be changed and upgraded. When we went and we looked, the changes in temperature, all of the tiles from all the bathrooms even falling off, so all of the bathrooms had to be redone. All of the furniture was changed, flooring redone and cleaned, all of the walls were repainted. Basically everything on the inside was completely refurbished, and the entire time the infection control team was always swabbing, always testing, and always ensuring that the area was safe. So it very much is practically the best place in the hospital to be, actually. It's the exact opposite.
And what staffing arrangements are there? And of course, you can speak to this to Dr. Bradshaw in terms of the private ward that's going to be reopened shortly. And how will its opening impact other wards?
Well, of course, as I said before, the nurses that came in from Ghana under the BLA, we have already had plans to deploy 20 of them to private ward. Of course, we will have to include local nurses for various reasons: orientation to our culture and our standards that we use here in St. Kitts in nursing services. So it wouldn't impact the other units negatively. Yes, so that was already in the plan to put, and this is why we were waiting to open the ward, waiting on adequate number of staff to open the unit. So now that they are here, we can comfortably say private ward will be ready to open soon.
Okay.
By we are looking at August, early August.
Okay.
August this year.
Yes, of course.
Well, just establishing the timeline. So
yes.
You're talking about a few weeks. That's about maybe like 3 weeks.
In a matter of
3 weeks, a month?
3 weeks,
2.5
weeks, thereabout.
All right. Okay.
Yes.
Certainly look forward to that opening ceremony. Now, quickly, Dr. Morton, and you mentioned the Smart Hospital, although I do have a question based on the prolonged heat that we're experiencing, but I don't think persons will forgive me unless I ask for an update for the Smart Hospital, because of course you also made reference to it. So where are we with that?
Okay, so with the Smart Hospital, we had a small We had a small delay that was necessary. This was a small delay for now to help to save us a lot of time in the future. We would have made some changes with regards to aspects of the structure and re-engineering to take advantage of a geological feature which we would have noticed in the area. So those changes that we had to undertake, it's going to prevent us from having to, number one, spend the amount of money we were going to be spending to do things such as pile driving and other things for the sake of giving the building that level of stability for something of that weight. And it allows us to achieve that level of structural integrity even in the absence of that. And it also drastically reduces the overall time that it will take to construct. So it is a pause for now that will end up saving us a lot of time in the future. That is what we've been undertaking recently. But that very most recent change, it has been completed. So we're going to see the mobilization of crews there very shortly. I'll allow the Prime Minister to make the official announcement for that one, but I'll just say it will be in the very near future. And I think persons are going to be a bit impressed with the speed at which we are able to now put up the entire building. So they're going to see.
Well, the Prime Minister does have a roundtable engagement tomorrow, so perhaps that is one of the things that it is on schedule. I don't know, I haven't seen his notes clearly. We, of course, will wait on the Prime Minister to make the announcement at the appropriate time. Finally, as we speak about the heat, we all feel it. What are some of the strategies that can be used by individuals and more so institutions as well, to those that cater to say, our most vulnerable in society? You look at persons who are elderly, persons with disabilities, persons who kill babies and younger children. What strategies are there that they can use to ensure that the sweltering heat does not overcome them?
Okay, well, one of the number one things that I always tell people to look out for is dehydration. People take the hydration status for granted. All human beings have this built-in mechanism to allow them to survive in a state of like a mild dehydration and still function. And if you had to take the average human being up, that's up and about their business, they actually have a mild state of dehydration and they're just used to functioning that way. That's one of the reasons why when persons are ill and they go to hospital, sometimes they give them some drips and it helps everything, because this person, one of the background things was that they were dehydrated. So when the temperatures are this high, it worsens it. And it's just to make sure that persons are getting enough fluids. That alone can work a lot of wonders to prevent any of the negative side effects of the heat. And of course you have to pay attention to your surroundings. Wear head coverings if you're going to be out in the open. Minimize the amount of time that you're out in the open during like those midday time periods.
And also, when you spoke about babies, you notice even in the heat, some babies are wearing hats and long sleeve. So you want to dress them light during the day. You want to increase fluids for babies as well. Breastfeeding, breast milk is 99% water. And so we encourage our mothers, our young mothers who are breastfeeding, to continue to breastfeed or increase the amount of breastfeeding to ensure that the babies remain hydrated. Of course, with the elderly, we want to ensure that they are hydrated accordingly, because as we get older, certain systems in our body also age. And so our body signals us to drink more, and so for the elderly it may be absent. So it is good to ensure that they have access to water, fluids whenever they need it. So it's important. But most of the time when the elderly come in hospital, the first thing that is diagnosed is dehydration.
And one of the ways to detect dehydration, I believe, is through our urine. It's the simplest step.
Yes, easy. Skin turgor. Pull the skin.
What happens?
When you pull the skin like this, it stays pinched.
Oh, mine isn't pinched, is it?
So you're fully hydrated.
No, but yes, you could also look at the urine.
Yes.
So the darker the color,
Yes.
usually the more concentrated it is. So.
Yeah.
Okay, and one of the things that I discovered, very mild, that can happen from dehydration is kidney stones, which can be extremely painful.
Yes.
I discovered that very recently. I was not aware of that. But certainly that's something that we encourage persons to drink more fluids, and where you can avoid the sun. I know we encourage persons to walk and to be fit, and that's also very important. But these days, depending on how far you may have to walk, it may just be if you can get parking space. So just drive your car, or make sure that you take an umbrella. Umbrella is not just for rain these days, especially since we've had less of that too. So we all have to adapt to climate change. Unfortunately, we're out of time, so I'll have to leave it there. There is a new health program that the ministry has that persons can follow. I believe it's a weekly program, Doctor?
Yes, Tuesdays at 1:30.
Right.
That's what I said.
I recognize you were on yesterday as well.
Just yesterday.
I see some information as well. So much happening within the Ministry of Health. They can go there as another source to stay informed. And so we'd like to thank you so much, Dr. Rondalyn Dennis Bradshaw, Principal Nursing Officer, and Dr. Jenson Morton, the Director of Health Projects and Strategic Initiatives. Thanks for being with us on InFocus. We certainly look forward to welcoming you again sometime soon.
Thank you very much, Mr. Richards.
We'd like to thank you, viewers and listeners, for joining us for this edition of InFocus. We trust that you will join us next week at the same place, at the same time, for another edition. We'll be hearing from Dr. Clark, Dr. Joel Clark, Honorable Minister of Environment, Sustainable Development, et al., who will be presenting on a very important meeting that she is going to be participating in at the United Nations. Until then, I'd like to thank you so much for being with us. Join us next week. I'm Ian Richards.
Join us every Wednesday for InFocus, a weekly talk show produced by the St. Kitts Nevis Information Service, where we provide exclusives with key persons within the government and discuss pertinent, relevant, and interesting matters that affect us all. Tune in every Wednesday, live on ZIZ Radio and streamed live on Facebook at SKNIS Media and ZIZ Online. InFocus, your government, your business.